Good morning. My name is Patrick Whitting, and I'm a physical therapist here in Rockville, Maryland with Restore Motion. And welcome to Pediatric Pelvic Floor Physical Therapy. We just wanted to take a little time to explain what we do and how we do it, and give you all some options of what you can do that will help your patients or your future patients. I have been a physical therapist for about a little over 20 years. My specialty has always been orthopedic physical therapy, and I'm also a male pelvic floor specialist. So we work with a lot of disorders of that, and we've just recently started doing more and more pediatric pelvic floor and working with that population.
My name is Christina Shea. I most often work with female pelvic floor patients specializing in postpartum, but in the last 2 years, I've actually had a chance to work with the pediatric pelvic floor population, and I noticed that there really is a huge need for this group. So during this presentation, we just wanted to touch on some patient and parent education regarding common dysfunctions that you guys will probably see with pediatric GI and what to expect during a pelvic floor PT session for pediatrics. All right. So earlier this year, we actually had the chance to meet with Dr. Serrano, Dr. Hong, Lisa Dreyfus, Katie Rawal, and a bunch of other people in the Georgetown GI team, Georgetown GI pediatric team. And we really just wanted to discuss kind of what we're going to discuss in this grand rounds, but what we do as physical therapists. We also wanted to just touch on and collaborate about how we can better help on our end, and then how we can actually better work together to help the well-being of our younger patients. And so we were thinking about doing this grand rounds would be great because we can touch on the new generation of physicians, of upcoming physicians, to help us spread the word about this field. And also we discussed that we could create a type of promo video, and this promo video would be helpful for not only healthcare providers, but also for parents and patients, so that when they do schedule with a physical therapist, they have an idea of what to expect. So we're going to play this video, and it'll sort of give a glimpse of what we'll talk about a little bit more in detail in this presentation.
Here at Restore Motion, we specialize in pelvic floor physical therapy for women, men, and also kids. The most common thing we see is constipation. And constipation is not as simple as it sounds. A lot of times constipation is used as an umbrella term.
So parents, when you're bringing your child in for these kind of situations, for a urinary problem or a defecation problem, a problem pooping, it's usually an indication that there's something going on with the pelvic floor and the way that that's functioning. So your pelvic floor is that area in your pelvis that are in between those two sit bones that you're sitting on. And in children, all of these muscles are still developing, and they're still trying to figure out how to use them.
With toileting, sometimes it's hard to know when to hold and when to go. A lot of times with pelvic floor, kids will often hold too much, and then they won't know how to let go of those sphincters. What we do with pediatric pelvic floor therapy is we focus on exercise through fun games. So we'll run through obstacle courses, we will do balancing exercises, we'll do reaching and involve stickers, and bouncing with balls, catching balls, balancing on one leg, all of these fun movements that children should be able to do. This is a good way to strengthen pelvic floor and your core, and kids have fun while they do it.
So we expect in physical therapy that as you go from week to week, that the kids are going to visibly get stronger. They're going to get better at their exercises. You're going to see that they have more control, and they really enjoy that ability to be able to play these games and to do these exercises more efficiently, or to be able to stand on their foot for a lot longer. And then what we're also going to do is we're going to chart on a chart actually how well are they functioning, how well is the bladder functioning, the bowel functioning. And so you can see that progress. Both the child can see it because they're part of the mix, and the parent can see it because that's a really important component. You've got that parent helping, coaching the child through, because they really can't do this on their own. They need that whole team effort. They need the parent helping, they need the physical therapist helping, and they just need that enthusiasm that's behind it all to get them to a point where they can control these bodily functions and improve their quality of life.
Great, so I hope you guys enjoyed that video. We will have the link for the video at the end of the presentation, and the video is public, so in case you feel like you want to share it or you have someone you want to show, please feel free to do it. So this slide just really summarizes some of the conditions we mentioned in the video. So constipation being that overarching sort of common dysfunction that we see, which can lead to endopresis, which is fecal incontinence, urinary incontinence, rectal prolapse is often seen, and then also nocturnal enuresis, which is bedwetting. So first and foremost, when we're working with children, we also want to make sure they're ready to toilet train. And sometimes kids will waver between 2 years old, 3 years old, 4 years old. So with bowel and bladder, you want to make sure that they're actually having bowel movements around the same time every day. They're not having bowel movements at night, dry diapers at night, dry diapers at least 2 hours at a time. So that kind of gives you an indication that they're mentally and physically starting to get ready. With gross motor movements, you want to make sure they can climb. So when they're at the playground, make sure they're climbing correctly using reciprocal motions. They can squat pretty efficiently. All the big muscles that you need for toileting. Some fine motor movements would be able to unbutton and unzip their pants or their shirt or their clothes, being able to pull pants up and down. All these little movements will help them with that independent feel when they're going to the bathroom. And something that's really important is emotional readiness. So you want a child to have an emotional stake in toileting. It's not something that they just feel like mom and dad want them to do. They actually have to be motivated to try to learn to toilet and have that independence.
So in a physical therapy aspect, what we're working on is we're working on the pelvic floor. So I thought I'd just give a nice brief overall view of what the pelvic floor is, because that isn't usually an important part of what we all learn in school. I know it wasn't for us. So when we're thinking of the pelvic floor in general, we're thinking of all those muscles that are at the bottom of the pelvis. They're the muscles that are in between the two ischial tuberosities, the two sit bones that we have. Photo on the left is showing collectively that inner layer, which is called levator ani as a group, those group of muscles. The one on the right is an overhead view looking at the same thing. And right there you can see the anal opening and then more of a front passage opening. This is a female. If you look at it in situ, this gives you a little bit better idea of where it is in the body. So it's that sling underneath your pelvis. It's a whole bunch of muscles and they work individually for certain things, but most often we're referring to them collectively as that pelvic floor. It's that sling down there. So pelvic floor is also connected to the core, and core is a very important process that our group of muscles that we're going to be talking about for bowel and bladder control. Core muscles are muscles that don't move bones or joints. They fire and stabilize. So we've got at the bottom the pelvic floor. At the top of the core we have the diaphragm. So the diaphragm is separating thoracic cavity from abdominal cavity. Wrapping around all of those, around the trunk, are the transverse abdominal muscles. Transverse abdominals are the deepest muscles of the abdominal group. They're not the ones that move the trunk. They're the ones that fire. It feels like a corset around the body. They fire and stabilize. The fourth set of core muscles are the multifidi muscles that are in the spine. These muscles are too short to actually flex and extend the spine. They can't generate that kind of force, but when they fire, they're going to stabilize the spine and hold the spine into a certain position. Over here on the right, you can see that view of how that core is right there in the center of the body. It encompasses sort of that soda can or canister-like effect that's going on with the body. So that's core, that's sort of core in general. And why is core so important? Core has a lot of different functions for our body. The first one, and we call it the S's, the things that they do. So the first one is that they support. So we've got that sling right here along the bottom of the body. So that's going to house and that's going to support the bladder, the uterus, the rectum, all of those things. It's also going to be supporting the large intestine, the small intestine. So everything that's in that abdominal cavity, that's going to lend its support from that pelvic floor and from the core. core in general, that pelvic floor, the sphincters are really connected right into the pelvic floor. So their ability to open and close that individual sphincter muscle is really connected to that sling of pelvic floor muscles that are in the bottom. Also really important, we call it the subpump. So we've got all of this lymphatic system that's coming through the body, and we've got all of these great big parts of that are right there in through the hips and in through the pelvis. So that muscle action and that good strong muscle action is really going to help kind of push all of that through. So a very important part of the lymphatic system. And then back to what we were talking about before, that pelvic floor is really one of those main things for the core, for what we think of as core. The diaphragm, the pelvic floor muscles, transverse abdominal muscles, those really deep abdominal muscles wrapping around, and the multifidi muscles that are in the back. Of course, when we're talking to the kids, we're not going to be really talking too much about that depending on their age. When we're talking about their digestive system and how everything works, we really want to do it on a kid-friendly, on ways that everybody can understand. So a lot of times, I think everybody who works with pediatrics and works with kids knows that you've got to sort of change things up and make things more understandable for your patients. So we do a lot on communicating with the kids very truthfully and understanding what their systems are like and what they're doing in a way that they can comprehend and understand and not sort of feel ashamed about them. So we use the kid-friendly words, we use what's appropriate for their household, what they'll understand, and we make sure that we kind of put all of that into the mix when we're treating. So a lot of times when you're thinking of pelvic floor, if you've had any kind of experience with pelvic floor or pelvic floor dysfunctions, usually in adults, we're really isolated on how that pelvic floor works. That's where we start, and the actual controlling of those. In kids don't have isolated pelvic floor weakness the way adults do. Most of the time, it's a developmental process if they're having problems with bowel and bladder symptoms. And so what we need to do is we need to focus on the core muscles and the abdominal muscles as a whole and the way they're developing and controlling. So that's going to be our focus when we're dealing with the bowel and bladder problems as sort of that pediatric pelvic floor. So if you think about it, and you all probably know this a lot more, have studied it a lot more than we have, we're looking for those important gross motor milestones, because as the body changes, as the body develops, as the core develops, things are going to change, and as they sort of slide into place, as soon as you get one step to the other step, we all know this through developmental stuff, that's when the function can start to begin. So if those things haven't happened, if those milestones haven't occurred, you're going to have a problem with function. That's true for just about anything. So when we're thinking of bowel and bladder control, we're thinking of, in the quadruped stages, the really important things are the development of those spinal curves, the development of the proper ribcage diameter and the diaphragmic function, the function of the diaphragm, and that develop of the scapular stabilization control, which is going to be part of that trunk control. As we keep moving on, once they get into the static standing phases, we're looking for the development of all the postural control muscles, the development of the proper diaphragm orientation, and the activation of those pelvic floor muscles. So again, all of those things have to follow each other and they have to develop. Otherwise, how are you supposed to engage and utilize them? So we're asking a lot of questions about if there's any sort of developmental delay. Did the patient not crawl, but then went to the standing? Was there that jump in the developmental delay? Anything that the parents can give us, or any kind of clues about what's going on that might hinder the patient's ability to start bowel and bladder control. And in this case, when we're talking about once they come to us, that development of the spine as they're going through, so not till about 1 to 3 years old, depending on how that's growing, how that's functioning, and how strong that is, that's going to be a real big determination on what their bowel and bladder function is going to be.
So what else is really important is that diaphragm positioning. So the goal really is to teach posture and muscle inhibition or activation, depending on which one they need, to be able to allow that optimum pelvic floor function. So that doming is actually, we call it the zone of apposition for breathing. So when you see a child who is very flared in the ribs, you can think about how that can affect the diaphragm. So if they're very stretched out in the diaphragm, they're going to get that lower cross syndrome. And what that lower cross syndrome is when they have a really extensive lordosis in their lower back. So their lower back is tight. Hip flexors have to compensate for that, so they're tight as well. And you get very overstretched obliques and hamstrings. So if you think about what happens and what trickles down when a diaphragm isn't working, they're going to have to use accessory muscles to breathe. When they're doing that, they don't get as much thoracic rotation in their play or their movements. Their center of gravity is going to change, causing them to have to lock their knees. And then also, most importantly, to point it back to our specific field, they're not going to be able to engage or find those muscles as efficiently. So when we see that prominent rib flare in the kids, that's something we really want to focus on first before we train the specific muscles of the pelvic floor.
So that's one of the main things we're looking for. You need that core strength that's going to develop that intra-abdominal pressure, and that pressure is actually going to make the rectum work better. It's going to make the bladder work better because you're going to have that opposition, and it should be a natural, relaxed kind of push for it. It really shouldn't be something that you have to force. So we're thinking about posture and positioning. So just so kind of as something for you all to sort of start looking at is like, well, what is the posture of this kid? Is it developing the way it should be? That hollowed back, right? The really arched back, or the prominent pelvis, or the rib flare. So we're looking for these things, and we want that good control. And so we're going to test it because we're looking for specific responses to all of these things. One is the anticipatory postural response, and those are the muscles that activate the trunk and the neck muscles in preparation for a change in the position of the body. So those guys have to be functioning the right way. They also need good balance responses. So that's the change of the alignment of the body for the different segments in order to maintain balance both on two legs and on one leg. And then the postural stabilization mechanism, and that's the stuff that maintains that erect trunk posture over a long period of time. So they have to have the stamina to be able to hold that kind of stuff. So we're sort of looking at all of those guys. And so what we thought we would do is, now that we've been talking and you've been looking at slides for a little while, we're going to do a couple of the things that we test the kids on. So if you're with somebody, if you have a partner with you, or just stand up and you can sort of try these things, we're going to demonstrate our sort of postural tests that we do that are sort of kind of a quick and easy way to determine, oh, overall posture isn't kind of working, and you can work in through the spine or the abdominals, whatever sort of gets the way going. So on the first one, it's going to be the arms forward test, and this is for that anticipation response and the stability response. So your patient is going to be standing there, both feet on the floor, with their arms out in front of them, and you're going to push down on the hands and create sort of a balance challenge for them, and you want to see how their body reacts. The second one is a simple single leg stand, and you're going to see how they react, how long they can hold it, how well they can maintain that upright posture. So what we thought we would do is we're going to come out of the sharing so that you can see us a little better. All right, and we're going to do this. So it's time for everybody to get up, put the coffee down. So on the first one, it's the balance response. So the patient is going to be standing in front of you, arms extended out into the front, and you're going to say, just hold on really good. Don't let me push your hands down. And you're going to push down, and you're going to look to how the body responds posturally to the force that you're putting down here. You don't have to push really, really hard. In fact, you can start a little bit slow and then push a little bit harder as you go, so you can increase the force. So what we want to see is we want to see those abdominal muscles pulling up and firing. So they're pulling up towards the chin. We want to see that head maintaining nice erect posture, and we want to see the weight of the body moving into the front of the feet. All right, so that's going to be all of those good postural muscles from the calves, from the abdominals, from the back in through the scapula, right in through here, holding the head, everything erect. Another variation is you can have them hold on to like a 5-pound weight or a 3-pound weight, and then they would just lift the arms up. So go ahead and lift your arms up, and then back down, and then lift up, and back down. And you try it about 10 times, 15 times. And a lot of times what happens, if they don't have the stamina, maybe they can react, they're going to start arching that back. They're going to start going back on the heels. They're going to start pushing their bellies forward, and they're just not going to be able to react. So if you're constipated when you're sitting on the toilet and you don't have those good postural muscles, you're going to be slouching, you're going to be slumping, and this is just not going to happen. That's going to be part of that problem. But you're also, if you're getting all of your support from your spine, you're not really getting that support from the abdominal muscles right in through here. And you can't generate that intra-abdominal pressure that you need to push down, which allows the pelvic floor to relax so that you can have a bowel movement or that you can urinate. Okay, so I'll try that. The other one is, Christina's going to balance today. I'm not going to balance today. So basically, we're just going to, we're going to stand, you have them stand on one foot. So you have them stand on one foot, and you want to see if the alignment is really good. If they're not arching their back, if they're not pushing through, it's all your typical balance things. When you look from the front, so go ahead and do from the front, you want to make sure that they're not leaning so far over to the side or extending the leg out. They're going to have all sorts of things. If hips go up and down, if their arms are flailing, that kind of stuff. So having to get them to do that, or you can somehow sort of distract them so that you can see different ways for their balance things. Sometimes just watching them walk in to see if they're a little bit wobbly. That is the kind of thing that you want to look for. It's a nice, quick way to be able to assess, does this kid have core control? And if the constipation is a problem, if the bowel and bladder issues are a problem, this is a nice way to think, maybe this is a musculoskeletal thing, maybe this is a developmental thing that the physical therapy can address to a certain extent. And we do that by strengthening with exercises. That's what we do. Right. Okay, this isn't a chair. There we go. So we do exercises, and we're going to address that in a little bit later. The other things that we have to address is the different kind of habits. So we have the time to sit there and talk to them about these different ones. And one of the best kind of tools that we have to do that with is called an elimination diary. So it's just a chart. It's a very friendly chart to track urinary and bowel output. So both voluntary and involuntary. So you can track accidents, you can track volume, you can do all that kind of stuff in a very sort of simple format that we do out for the kids with the little reminders. Let's see if this guy comes in. There we go. So here's a little bit bigger picture of that. So we have provided, I believe it's a PDF with the slide presentation that we have. So feel free to give this out to your patients or to copy it or to do whatever. You're more than welcome to use this. But basically what we're doing is we're charting for a 7-week period or for a 7-day period what's happening, when they're going to the bathroom, when they're having the accidents. Is it a urinary or is it a bowel movement? And it's a nice way to sort of check off. The kids can go in there and help. They can use stickers if they want to. You can hang it up on the wall. There's all these different ways to use this for the families. It's really good in several ways. First, it sort of finds patterns for the good and the poor habits. When are most of the accidents happening? Are they happening in the morning? Are they happening after meals? Are they happening before they have to go to school? A lot of times, all of the patterns that occur give a nice clue about why certain things are happening, why certain things aren't working the right way. It shows progress from week to week, because really just trying to remember when all of these things are happening doesn't work for either the child or the parent. And it really helps get the children involved in the process of getting themselves better. And a lot of times there's a lot of satisfaction in that when they can go back and see that they're improving. Proper toilet posture is really important for everybody. So that's adults and children alike. The reason that there's a certain posture for sitting on a toilet with those knees up on a stool, if anybody's ever seen the ads for the squatty potty, is that it takes the muscles of the pelvic floor and it relaxes the puborectalis muscle, which wraps around the rectum. And if your feet are on the floor, it's going to pull or kink up, that muscle is going to kink up the rectum, which makes it harder to relax and have the bowel movement. So putting those knees up in just in that instance is the thing that relaxes the pelvic floor for everybody and makes it easier. So we definitely want to make things easier for the kids, and we teach them to do this. And we do that for everybody, actually. For children specifically, you've got to remember that they are not sitting, or sometimes they're not sitting on a size appropriate toilet. The only thing that they have is the household toilet, the adult toilet. So their balance can be impaired. They're not going to feel comfortable on it. Excuse me. That's another thing to sort of talk about, because if they have a potty seat, that's good, or if they have something that's helping them, but that positioning where they're not kinking up, but also that they feel like they can sit and relax, because it's always a relaxation phase that we have when we're doing the bowel movements and the urination. So we've got to make sure that they're comfortable on the toilet. And diaphragmatic breathing. So here's where the core brings in another good aspect of what's going on. Bowel movements and the urinary process is always a relaxation phase. So that pelvic floor has to relax in order for those sphincters to open and so that we can expel. And the easiest way to get that relaxation is to use diaphragmatic breathing, because when you diaphragmatic breathe, that inhale that expands your core, all different parts of it, and then the exhale contracts all that, it gets all of those muscle fibers moving just a little bit, which is going to help them relax. It's going to take away that tension or that gripping that you might be feeling, and it's going to help everything moving. So a nice relaxed diaphragmatic breathing as they're sitting on the toilet, that allows everything to function a little bit better. So we practice a lot on the breathing, and it's surprising how kids don't know how to breathe sometimes. They get too excited, or they're using their accessory muscles like we talked about if it's developmental stuff. So a lot of times just teaching a child the correct way to breathe is really going to help how things function.
Perfect. So we're going to get into exercise. This is the fun part. With our kids and younger patients, the trick really is to teach these skills and techniques through directed play. So breathwork, as we said over and over again, is super important to establish during pelvic floor rehab. And that's honestly with adults as well. We really, honestly, during the first session, probably about 90% of the session is focusing on that breathing aspect, making sure they're breathing with their diaphragm, not using their accessory muscles. And by accessory muscles, we mean, their low back extensors. You don't see like their scalenes and their SCMs or upper traps kind of getting into play when they start to breathe. With parents, I like to explain and use the cue as if you were watching a newborn breathe and as they were sleeping. So when a newborn's sleeping, you can really see that effortless breath. As they inhale, their bellies and lungs inflate, and as they exhale, they kind of go back to baseline. So that kind of gives you a visual of how breathing should be before life and everything kind of takes over. So this technique should be the same pattern based on with older kids, with adults, and also with some of the population that we're seeing. So I like to actually use bubbles and balloons a lot. So now with COVID, we don't use them as much during our session, but I'll have them take that home with them. The bubbles actually help a lot with the constipated population, which they're having a really hard time having bowel movements. So they're on the toilet and they're straining and straining, they're pushing really hard, but nothing's happening. They're even playing into a little bit of that prolapse or increased abdominal pressure. And so the reason I like bubbles is, one, you need to be able to generate enough power to blow a bubble out. But you also have to be able to calibrate so that you are blowing just hard enough so that the bubble doesn't pop. So you get this great reward of creating a bubble, and it's fun. That's a way to actually teach them how to use their respiratory muscles. And then with respiratory muscles and breathing, sometimes you need to engage 10%, right? And sometimes you need to engage 80%. So it's a way to sort of start to teach them how to titrate that level. So we're actually going to do a quick activity. We're going to work on a quick breathing activity. And this is because another part of breathing is that sympathetic drive. So when you're going to the bathroom, either peeing or pooping, you have to be in a parasympathetic state to be able to successfully have a bowel movement or to void. A lot of times these kids are so amped up and so they are having a hard time focus so that they can't ground themselves. So this is actually a technique that I like to use. And OT actually taught me this technique at OT that I mutually work with that it also kind of plays into sensory. So we're going to do this together. This is called the 3-3-3 breathing technique. So I will count, but I want you all to actually close your eyes. We're going to breathe in for 3, hold for 3, and then exhale for 3. So I want you to go ahead and breathe in on a count of 1, 2, 3. Hold that breath for 1, 2, 3, and then exhale for 1, 2, 3. We're going to do it 2 more times. So take that time, breathe in, 1, 2, 3. Hold your breath, 1, 2, 3, and exhale, 1, 2, 3. Last one, breathe in, 1, 2, 3. Hold your breath, 1, 2, 3, and exhale, 1, 2, 3. Many times the kids just need this short time to reset their nervous system, try to ground so that they know what they're doing. The reason I also like this is because it's easy to remember. It's just 3 seconds, 3 seconds, 3 seconds. Sometimes I will actually have my kids, they're kind of bouncing off the walls and they'll be like, I need to do my 3-3-3 breathing. It's like, all right, do it. So it's easy for them to remember. If we teach them something that's too complex, it's going to go over their heads. So we just want something that can be efficient and successful in that way. So this is actually a picture of what our gym sometimes looks like when we put out our obstacle courses when we have our kids. So with younger patients, again, we have to make exercise fun. So we really try to layer in these developmental positions. So we have creeping, crawling, having them on hands and knees, kind of like what you saw in the promo video, half kneeling, and if they can, running, skipping, watching those reciprocal patterns. So as they're doing these tasks, what we're doing as physical therapists is we're asking the questions, are they biasing one side or not? Are they able to use their core, or are they able to functionally balance? Are they reciprocally using both sides the same way? And if they use their upper extremities for certain balance activities. So those are the things we look out for while they're doing this fun playing activity. And normally the patients that we have honestly been to so many different healthcare providers. Sometimes they've been poked and prodded for tests. Sometimes they're already on like a cocktail of medications. So this is a chance in PT for us to show them that working on toileting, working on breathing, muscle strength can really be fun. So it kind of ties into what we talked about before with that emotional state. We want them to want to get better. So in order for kids to understand why it's important and have a good time doing it is that you have to make it fun so that they have that stake in their treatment plan. All right, so I actually took out the conclusion quote of this article, and it states that the new field of pediatric pelvic floor physical therapy is a safe and effective intervention for children with dyssynergic defecation, causing and contributing to chronic constipation. And this is particularly in children who have comorbidities, including anxiety and low muscle tone. And I would say a lot of the patients that we see have that anxiety and low muscle tone. So I like this quote because 1, it really validates what we do as physical therapists for this field. And 2, it emphasizes how this is a new field. So we really wanted to do this grand round so that we can spread the word and we can advocate and educate healthcare providers in this sense, and also parents and patients so that they understand that if they see patients with toileting issues, that PT is a line of defense that they can use, something that's not scary for the kids either. And it's a great thing because it's a new field, we can all sort of be on this forefront to be able to help and educate. And again, so a big part of it is the team. So the multidisciplinary team. As healthcare providers, one of our really important responsibilities is to be able to refer. So we want to be able to refer to the appropriate branch of this healthcare team. So we'll go over what each branch does, so that if you are seeing a kid overall, you can kind of decide which direction they need to go in. So with physical therapy, as we harped on, we really focus on the musculoskeletal aspect. With occupational therapists, they have the power to look into sensory processing disorders if they have any. Psychologists are really important for the mental health aspect. And I find that with my patients who are around like teens, maybe older than 10, having that psychologist is really important because they probably have been dealing with this for a long time. And it really gets into their quality of life. It gets into how they feel socially, and also just what they feel like they can and can't do. So that's a really important part of it. GI specialists, just like you guys, to help with tests, diagnoses, and help titrating medications, and pediatricians for overall health. So I really think that overall treatment is much better when we have that multidisciplinary team. And that is actually it. So I want to thank all of you guys for really joining us. I know it's early and it's Friday. So thank you for joining us. And I wanted to just thank again the whole GI pediatric team at Georgetown, and Dr. Serrano, Dr. Hong, Katie Rawell, Lisa Dreyfus, and also Rachel Potts for setting this up and helping us work through all of the technical problems with it. So I think it went really well. And we'll be here for a little bit. We have some more time, so we'll take any questions that you guys have.
And we'll just leave this slide